Okay, the floor is yours. Christian?
Okay, so like I said, I'm an account manager, but my history is a radiographer and a CT application specialist, which I did for about 5 years, which is long for an application specialist. Then I had kids and got out of it and went back to clinical, worked at Nambour General doing cardiac. Pretty similar place to here, really, like Nambour General, except we're probably a little bit luckier in that we don't have quite the problem with recruiting radiologists. So as I said, Michael just told me that you guys are about to embark on coronary CT, or CTCA as people like to call it, and I thought I'd just come up and give you a few little insights. It really came about because one of your colleagues is going to Townsville to have a look, and Michael and I started a discussion. Maybe we should do a little bit of an introduction to everyone for cardiac, so when you do it, you sort of know what you're doing. So the things that we might look at today are, and by the way, stop and ask any questions you like. Like, I don't really want to make this like a formal presentation. I'll stand up here and gas bag, although I'll do that if you don't ask any questions, but just break in any time and ask a question. So we're going to look at who's the appropriate person to do a CTCA on, and not everyone. We're going to look at some preparation, which is really important, contrast, and then a little bit about the scanning. So we won't go in massively into the scanning, because the scanning side of things, I really believe you're better off sitting there doing a patient and you'll understand what you're doing a little bit more with the scanning. But the preparation and contrast is actually pretty important. So who do we scan? So we break up cardiac patients into low, intermediate and high risk patients. So our low risks are people who have like a family history and maybe had an episode of chest pain. Then we have an intermediate risk where they'll have a family history, increasing episodes of chest pains and maybe some ECG changes. Then high risk, we have positive. So the intermediate risk guy might have some troponin rises as well. Troponin is an enzyme that's released by your heart once it's come under stress. So if you've had a heart attack, you'll have troponin in your blood. And I guess the tricky thing for an emergency department, and no one really has taken this up yet, you'll probably look at your algorithm within your emergency department, and if a person comes in with chest pain, they'll take a blood test, check for troponin. If it's positive, they then have to wait 8 hours, do the next troponin test before they can send them home. So I really think there's a place, if we're doing it on the right patients, where we can do emergency patients within that 8 hours and send them home earlier. Because the one thing that coronary artery CTCA is good at is a negative predictive value. So if you see no pathology there, there's no pathology. Where it gets tricky is when you see some pathology and you want to try and quantify it. That's where it gets a bit tricky. But if there's no pathology there, there's no pathology. So who do we do it on? These guys. So these are the best people to do it on. The reason is ECG changes may not have taken place, and these guys, the high risk, if they're currently having chest pain and they've had ECG changes, they're having a heart attack. So they should go straight to cath, or in your case, probably straight into an ambulance or a helicopter and get somewhere with a cath lab, or down to Friendly's. Friendly's yeah, they do, don't they? I should know that because they've got our machine. So that's who we do our CTCAs on those low risk and intermediate risk people. So they're the ones who are really good. And when we first brought this out, particularly the Queen one that went into Monash, which is our luminary site for this, a guy called Ian Meredith, I don't know if you've heard of him, he's a cardiologist, did the first sort of cardiac cath and stenting in Australia. He's on the telly with the Heart Foundation and all that sort of stuff. He said, it's these guys here who come into an emergency department, they have their troponin test and they still send them home, and sometimes they still die. And like they're low or intermediate risk, but they've had a big plaque, and you don't know that because that chest pain is eased, and they end up going home and dying. So that's where, for you guys in particular, where you can be really helpful for people with heart disease. So preparation. So preparation is like, you cannot put enough emphasis on prep for cardiac. When I was an application specialist, you'd always get a call about 6 months later and they'd say, our cardiacs are gone off, we need you to come back, there's something wrong with the machine. And say, okay, so we go back, and all of a sudden you go there and you know, they weren't cleaning the skin properly, and they weren't attaching ECG leads, they weren't getting good traces, or they weren't prepping them properly with beta blockers. So prep is where it's at. Like if you get your prep right, then CTCA becomes a breeze, particularly with your machine. So the slides that you're about to see now come straight from our course that we do down in Sydney. Hi Michael, how are you going? So I thought I would, rather than reinvent the wheel, I'd bring these slides up, but they're pretty busy as far as I'm concerned. So we'll just look at a few of the important points in here. So we've talked about those things there. And we know that undesirable candidates for CT, they're those high risk patients. But there's some other things we can look at. So sinus rhythm. So the way a CT works is all to do with sinus rhythm. And I don't know much about, we'll talk a little bit more about ECG traces, but it's that tall R peak that you see on an ECG. That's what triggers a scan. If you don't get those, then the machine gets confused and it can't work it out. And there's a couple of things we do to fix that along the way, which is your scanner's really quite good at. But it was a real challenge in 64 and 16 slice scanning to do that. I don't really like the next one, body mass index below 40. We're doing it on big patients now, and you've got the new detector. Like I don't really think that's a get out of jail free card saying that this person's too big, potentially. Normal renal function, well, that's for any CT, isn't it? Able to follow instructions and remain still. So the instruction things is really important because you need your patient to be able to hold their breath. The one thing that can kill a cardiac, even with your scanner, is if they breathe throughout the scan. It's not much you can do to really get that data back because it's just movement there and you've captured it right on breathing and there's not much you can do about it. Patients who can tolerate beta blockers. So everyone talks about, oh, we can scan without beta blockers. Yeah, everyone can scan without beta blockers, but nobody does because it'd just be silly. You increase the dose to your patient for the sake of a $10 pill, that's really safe. So everyone beta blocks. So subnitral nitroglycerin, that's just that GTN spray, the same stuff that you get if someone's having chest pain in an emergency department, lift your tongue, spray it under there, and it dilates your blood vessels. So one of the questions I had when I was an application specialist was to a cardiologist, and that was, well, if we're giving them nitroglycerins and we scan, then their vessels are bigger. So if they do have a soft plaque and you're looking at which stent size to put in, you've just made their vessel look bigger. And I thought, well, surely that's wrong. And he said, no, because we always oversize our stents. So we'll actually give a direct injection of nitroglycerins into that blood vessel and then do our measurements. So it's important, if you can, to have that. So nitroglycerin is important. However, some people can't tolerate it. And the other thing is, there's been heaps of stuff, and I'm not sure what we actually say now, but we used to give nitroglycerin scan straight away. Then we went to like a 5-minute delay, and now I think it's out to about 7 minutes that they say for nitroglycerin, but that seems to be ever changing. The patient, if you give too much, will get a headache as well. So it's a good idea to warn them of that so they don't freak out and say, oh, I've got a headache after the scan, and just say that's normal, take some Panadol or Nurofen, whatever you usually take for a headache, and it should treat it. Arms above their head. Sounds trivial, but if you can't get their arms above their head, it will affect the image quality of your scan, no question. In fact, one place I worked at, well, in Amber General, I just worked at, if we had ladies with big boobs, we'd actually get cushions and push them up out of the way, push them up and get a strap and put them across. Kept the dose down and made our image quality better. I didn't do it. I got a nurse to do it.
Question, just back to, if they can't put their arms above their head, would you still do it?
I would have a chat with the referrer or ideally the radiologist. Depends on the size. Like if they were massive and they couldn't get their arms up, like they probably wouldn't fit through the scanner anyway, potentially. But I'd probably still give it a crack, to be honest, because the dose these days is so low. Like when this first came out, we're giving like 24 to 30 millisieverts for a cardiac scan. Now we give sub 1 millisievert, and generally speaking on a QE1, it's around that 1 to 2 millisieverts. So back then it was a real issue because we were already giving them like a nuke med scan kind of dose, and concentrated on the heart. So, you'd say, oh yeah, but for a chest and abdo, you might get up around that maybe on a big person, but not concentrated into one specific area.
So it's the dose mostly that dictates.
Yeah, that's why I would.
Quality of the scan?
Yeah, you would get artifact, but with. So you guys have got CMAR, right? So CMAR can be used on cardiac scans. They're on ECG gated scans, I'm pretty sure, but I'd have to double check that. So that could change things a little bit, but I probably would still do it and see how it went. So 18 gauge cannula in the right cubital fossa. Anyone know why we put it in the right cubital fossa?
They're not getting artifact.
Is there any time that you wouldn't put it in the right cubital fossa? It's a tricky question.
If they can't have an injection into that arm?
That's true too. Didn't think of that one. Good point. Yep. If they'd had lymph nodes and things removed, breast cancer perhaps. But so the reason we put it in the right side is so yeah, well, you would if it was dextrocardia, you'd turn them around. It's a faster route to the heart. That's all. But the only other time you wouldn't put it in the right is if they had a coronary artery bypass graft, and if they used the reamer rather than the lemur, which is weird. So the reamer is the right internal mammary artery, which they take off the wall and they attach it to one of the blood vessels. So if we put it in we put it in the left. So if you've got a cabbage patient, it's 90% of the time they'll use the lemur because the left side lines up perfectly with the LAD, which is your left anterior descending, which you'll get to learn. Don't worry about anatomy for the heart. It actually gets really easy because it's all the same all the time. There's a few minor changes that happens in a few people, but generally speaking, it's not hard. So the lemur will come straight down and attach to the LAD usually. So if you were to put that into the neat contrast coming up through here into your subclavian, and you've got, the subclavian sitting below it where the lemur comes off, you get artifact and you could possibly not see the origin of that lemur. So that's why it's important. But generally speaking, it goes in the right antecubital fossa. Definitely 18 gauge on big patients because we could use up to 6 mils a second, maybe even 7, but 6 is generally as high as I went. So you could consider putting a 3-way tap in case you use IV beta blockers. So we've gone from using oral metoprolol, is the name of the beta blocker we generally use, to giving IV beta blockers. I think the jury's out on that a little bit. I personally, this is only personally, am a fan of oral beta blocking. I think it lasts longer. So the half-life of an IV injection is about 10-15 minutes. And that you can get yourself into a little bit of a problem with IV, I reckon, because so you give 5 milligrams of IV beta blocker, right? And their heart rate comes down a little bit, but it doesn't come down enough. And so you sit there and you wait for 5 minutes and then you go, oh no, we'll give another 5. Comes down a little bit, not there. And then you think to yourself, I wonder if that first 5's worn off yet. And now I'm just injecting another 5 mil on top of that, but that first 5 mils is gone. So I think that makes it, I find it a bit tricky. So I'm a fan of oral beta blockers, and there's heaps of different protocols you can use, and we can't really tell you what to use on that. You'll have to come up with your own policies. However, if you know Steve Lane, I'd be calling him because he'd have access to some pretty good IV beta blocking protocols from the Amboy General that a guy called Craig Maskeel has come up with. Then he trained at Prince Charles. He's really good at cardiac stuff. So he's got a pretty much like a chart. It says kilograms, heart rate, how much metoprolol to give. All this stuff we already know. We know that. Okay, so we do usually, well, not usually, we really need to get blood pressure before we give metoprolol. So if you're one of the departments that's going to give oral metoprolol before they, in the department, you should take a baseline blood pressure beforehand. That's just to ensure, because it can drop your blood pressure giving beta blockers. Well, yeah, you'd be right there. But I think beta blockers is the same. Yeah. So, but it's important to get that baseline before they leave the department. You need to give it again, make sure they're okay. So once the patient's optimal, you can begin scanning. So 75% of a breath hold each time. That's pretty specific, but I'd just make sure that the patient understands what the breath hold is. And it's usually breathe in, breathe out, breathe in again and hold it. We usually give them a bit more time. And your gantry, you can walk them through that on your gantry there. So I don't think this is emphasised enough, a good signal. You really do need to get a good ECG trace, or that's when it gets hard. So these are just some examples. So you can see here, so this is a trace that's come off the machine. You can see there's no R peak. So the system just goes, well, I don't know where it is. So this grey that you're seeing here represents exposure. So the machine just goes, well, I don't know what's going on, so I'm just going to expose and do what's called retrospective scanning, which is higher dose. You guys actually don't have to worry about that because you're going to be doing it in one rotation. That's off a 80 row system of prime. And this is just showing you getting some interference. on your ECG tray. So being able to pick those things, I guess, is important. That said, there's still some pretty good R peaks on that. If I couldn't work out what the interference was, I'd still scan on that. Okay, so this again is just talking about suboptimal ECG trace. So it's got a little ectopic here. I'm not sure there's much you could have done about that, but I think the point here is that these R peaks aren't high enough. So there's a bunch of things you can do. When you've got them on the table, you can change the lead. You could, reposition the leads, or you can change the lead. There's a couple of different options on the actual ECG machine, which nurses probably know more about that than me. I don't actually know what it does, but some of them work better for different patients. And you just try, there's 3, and you just try each one and see which one gives you the biggest R peaks. And again, that's just a bad setup. And again, you guys don't really have to worry about it because this is off a prime, so which is the 80 ray detector. You guys will be doing it in 1 beat, and we'll talk about that. That's just showing what an R peak is. And they're not R peaks apparently. So the interference every 0.35 of a second. So what's our rotation time? 0.35 of a second. So a lead's probably in contact with the gantry. That's just showing you where to put them. There's no point showing you that because you'll be shown when you actually get to do it. But it is important to get good contact. So any questions about preparation? Is there anything else you've heard? No? All right, so IV contrast. I guess the important thing with IV contrast is you guys are all good radiographers and I'm sure you've done plenty of injections of contrast. I think really you need to know what you're aiming for when you're injecting contrast for a cardiac. And there's 2 real protocols we use. So this is what you'll use most of the time. And it's nothing fancy, it's just got a saline push. Does anyone know why we use a saline push?
Like contrast that's in there.
That is a very good reason, and there's one other important reason.
Get rid of the contrast out of the right side of the heart.
Exactly. Do we know why we want to get it out of the right side of the heart?
Can't remember.
So there's a really bright thing here.
Oh, yeah.
Yeah, so that, if you imagine, you think back to a CTPA and this would be bright as anything. So you can get artifact, which could affect this right coronary artery. The right coronary artery is the hardest artery to see. It has the highest velocity out of all the arteries as the heart beats. So if you get a good right coronary, so whenever you're checking a coronary, and if anyone says to you, oh, do you think that's a good coronary? Look at the right. If you see the right's beautiful, circumscribed, no shadowing or looking fuzzy, then you know that it's going to be a good study because most of the time the left side will be primo if you've got the right coronary artery looking like that. So that's why we do that. So the only other, so you can see that's a biphasic. So I'd still say that hasn't worked. I don't know why you put that slide in here. So this is what they're trying to do here is they still want to keep some opacity in the right side of the heart so that you can do a right heart study as well. We don't really do it much anymore because when we used to do cardiac and we were doing retrospective scanning, we would get the whole phase of the heart so we could get ejection fractions and things like that. So we could see it in diastole and systole. You can do that with echo, which is no dose to the patient, and you can do it with MR as well if you want to. So we don't really do too much of that these days. And it shouldn't look like that. It shouldn't be that dense. So it should be opacified but not bright. And can anyone see the right coronary artery there? It's supposed to be sitting in there. I suspect that's it moving in and out. So that's not a particularly pretty slide. What injector, did you guys get the Maxion injector? Yeah, good, so you know what that's going to look like. So it's a little bit different for a coronary artery bypass graft, and your application specialist will talk to you about the way you want to do this. So the trick with these ones is that you actually still want to keep your lemurs and your venous grafts opacified. So most of the time we actually we scan bottom up, so that you do the bottom part first because the blood's going this way, right? So you scan with your flush, so you've got nothing in the right side, and then you'll do a scan here, and then the machine will move and you'll do another scan at the top just to cover the top of the coronary. So you want to follow that contrast up. So you usually do it at the bottom. But to give yourself a bigger window of opportunity to get that contrast in those lemur grafts, you just do another injection of contrast straight after, but at 3.5 mils a second like you would for a normal angiogram. So it's very important to know if someone's got a cabbage. So history, like in any examination, is imperative. You've got to ask.
So, just how would you know if it was a lemur or a rema that you had?
Hopefully ideally the patient would come with that information. If they've come from a cardiologist, you're even lucky sometimes to get a mud map where they actually, because you know, so a quadruple bypass will usually be one lemur graft and then some venous grafts going to different blood vessels depending on which ones were diseased. So it's knowing where they implant can be tricky from the aorta, with a venous graft from the aorta down to whatever blood vessel. So if they didn't know that, you know, if you saw a big scar down the middle of their chest, you'd say, "What's that from?" Well, I've had some surgery, but it could be a valve replacement, could be anything. So yeah, you don't know. If they don't know and they don't tell you, there's not much you can do about it, I guess. But you need to ask that question, and you'll have, if you don't already, you'll have a dedicated coronary sheet that you'll go through to ask all these questions to remind you.
But the patient should know whether it was a left or a right.
No, they won't know. I'd assume it's a lemur. Unless they...
Wrong. What if you make that assumption and you're wrong when you're scanning?
Cardiologist/doctor's fault for not writing it on the form.
Yeah, pretty much, but it doesn't help the patient, I guess.
So it should be written.
Yeah, it should be. If it's... I mean, the only place you're going to run into trouble is at origin. So if it means you need to go back and just do another rotation just through the origin, perhaps, to check and make sure that's okay. It's pretty rare that an origin, to be honest, of a lemur or rema will stenose. Like, it's really the venous grafts that aren't, you know, they're not made for high pressure blood. So they're the ones that usually, if anything's going to stenose, it'll be the venous grafts usually. But yeah, if it is a rema, then and you've scanned injecting into the right side, you might struggle to see it. And the only thing I could suggest is rescanning. So we'll just go briefly now through some scan modes. So a calcium score is what we tend to do with most of our coronaries, although we came up with a protocol that we only, I think it was men over 60 and women over 65 would get a calcium score. But again, that's something that you probably need to have a discussion about with whoever's going to be running the show. And it's just one rotation for you guys, really easy. So the important things to remember with calcium score is, for you guys, again, it's easy because you do it in one rotation, but you have to do it in one breath hold. So calcium scores can actually have a longer breath hold than the coronary scan, and that's just because of the way it scans. It's like a step and shoot technology. And the other thing is, don't mess around with your algorithm, like your FC values. So it'll be set up for you, but if you think, oh, I think I can get better image quality on that by going to like a smoother algorithm, because we use really low dose on calcium scoring, don't do it, because it works on Hounsfield units. So as soon as you change an algorithm, you can shift your Hounsfield unit, and that can mess with the calcium score. Does everyone sort of get what that means? Yeah. So what else, does anyone else know what affects Hounsfield units? One of your factors? KV. So ours are always scanned at 120. I don't think that's changed, but that'd be a good thing to check. So I never used to anyway, do a calcium score at 135 kV because it would shift the Hounsfield unit. So this is one you would do if once, so targeted CTA is good because it's like really low dose, but there's no window. And if it turns off what we call arrhythmia rejection, which we'll go into in a moment. And basically you do it on a patient who you know their heart rate, you're like 99.9% confident their heart rate's not going to change, and you want to keep your dose low. So I've seen this done on a patient who had increasing episodes of chest pain. She was an athlete, and the chance of her having coronary artery disease were 0 really, but they still wanted to do the scan, so they did this and kept the dose like it was 0.5 of a millisievert or something like that. She was tiny as well. She's an athlete, so that helped. So this is something that you would maybe embark on a little bit later when you've got lots of confidence in what you're doing and you select the right patient because you know it's going to work. So I wouldn't get too excited about that one. So prospective, we're not going to read all that. So prospective scanning is what the machine does. It anticipates the dose. So rather than turning the x-rays on for the whole ECG trace or the whole scan, or for your sake, from one R cycle to the next R cycle, we selectively just choose a little bit right in diastole, which is usually between 70 and 80%. So we will, I was hoping there'll be a picture. Oh, there you go. So we just turn the x-rays on in this section. We don't turn it on over the whole R to R cycle because that would give us a higher dose. Some things that would give us, well, where we don't have the option for, so CFA means cardiac functional analysis. So that's when we start talking about ejection fractions and all that sort of stuff, which we don't really do so much of anymore because we know we can do it on other modalities that don't give radiation. So we just pulse the dose on and off. So retrospective is the way we always used to do it, and we would do it these days if for some reason they wanted, to get that cardiac functional analysis information. But again, you need to understand that there's a dose penalty for doing it. But there are two different ways you can do it. So you can do a continuously high dose across the whole R to R cycle, or you can use what we call ECG modulation. So where we have x-rays on from the whole R to R cycle, but we just turn it on higher over diastole to get our arteries, and we still get the functional information as well. Does that all make sense? And don't get nervous about this, like the machine, if someone asks you, I want functional information on this patient as well, there'll be a protocol there that says CFA, CTA CFA. So don't stress about it. And that's what happens in a continual. It's interesting with the purple line thing. So yours won't do that. That purple line should just stay there and go boom, on and off. There you go. So it does not replace prospective CTCA. So that's just that target, back to that target CTCA stuff again. So the arrhythmia rejection is off. So that is important. So ignore that. So this, if you're going to do a targeted CTCA, this is what you do. You'd have to set all this stuff manually, give yourself a window, and it's not something you do until you're really feeling comfortable with cardiac, because you have to choose the phase, the number of beats, potentially. It's, yeah. Anyway, so this is a fairly confusing flowchart, but I get it. So first question you ask the patient, bypass graft? Yes, so you do a bypass graft. No. Is it for pulmonary vein ablation planning? So pulmonary vein, all we're really interested in is the pulmonary veins then, so we don't get too concerned about the blood vessels. So a lot of the times we don't even beta block the patient, we'll just come in and have the scan. If it's functional, which will be no, we go to prospective. So like 99% of the time, this is what you'll be doing. So prospective CTA, if the heart rate's under the 60, I reckon we'll question that a little bit when the application specialist comes to actually do your training. I think we could probably go a little bit higher than that. So if someone comes in and you've beta blocked them, or you can't beta block them, so asthmatics can't be beta blocked, for example. So because if they have an asthma attack, then that, and I don't really understand it, but basically what the beta blocker does is stops that person's ability to get over it somehow. I'm not too sure. Take a bit more research in it than I know, but if they've got asthma, you don't give it to them. So if their heart rate was high on your scanner, you've got a couple of options, but you'd probably do like a 2-beat acquisition. So that means that you'll do 2 rotations around the heart, and then the system's really tricky. It takes part of the information from one scan and part of the information from the other scan. So when we scan, we need 180 degrees of data. So if we've done it twice, then potentially we could get half the data from one rotation, half the data from the other rotation. So that means we only need 90 degrees of rotation from each scanner. So our temporal resolution is better. So a higher heart rate, we can use a 2-beat acquisition, and that way our temporal resolution is much better. Does that make sense? So obviously you can get a 3-beat, 4-beat, 5-beat, but what's the penalty? That's right, so you've just exposed the heart twice. So it's how much? Double the dose. So that's why we beta block, and we beta block hard.